Thank you, Jim, for introducing the Molecular Tumor Board, and it's really a pretty fantastic experience. It takes place weekly by Zoom. We have people from really all over the country getting together and with different specialties getting together in order to help patients. And what I'd like to do is, if anybody has questions, if you want to stop us and ask questions, we'll be happy to pause and answer them. And we'll also answer any questions at the end. But would love this to be interactive, so don't hesitate to stop us. This is what we're going to be doing. We're going to have a case presentation. Medical history, Dr. Jacob Adishek, our mentor, will be presenting that. Then we're going to talk about blood-based genomics analysis and recommendations, and Dr. Julia Elvin and I will talk about that, and tissue-based genomics, which I will talk about. Then dosing novel combinations, Dr. Meena Nakanjam, clinical trials, Vivek Sabaya, germline analysis, Catherine Skifos, and then we will update and provide a case study of a similar patient that we treated actually at UCSD. So we'll start with the medical history. And Dr. Adishek, do you want to go ahead and present the patient's history?
So I'll tell you about our patient. She's a 28-year-old lady who was first diagnosed back in 2009 with osteoblastic osteosarcoma. She was started on a trial of methotrexate, adriamycin, and cisplatin. She then underwent a surgical resection of a distal right femur mass, and that showed 35% necrosis. After that resection, she came off study and was treated with fosfamide, cyclophosphamide, doxorubicin, cisplatin, etoposide, and high-dose methotrexate, but then developed cardiotoxicity from the doxorubicin. And she had been followed for 4 years with just surveillance imaging after the resection. She then, in 2014, had a right femur implant placed, and she continued to be on surveillance. And then about 8 years later, she developed new pain in her right knee, which was October of 22. That prompted an x-ray and then CAT scan about 2-3 weeks later that showed a new 8.3 centimeter soft tissue mass in the vastus intermedius muscle. That prompted a biopsy 2 days later that showed high-grade pleomorphic spindle cell sarcoma, which was best characterized as a recurrent osteosarcoma from her 8 years history. From that, she had a staging scan that showed multiple pulmonary nodules believed to be metastatic disease, and a PET scan that also showed the right femur mass, and then the pulmonary mets lit up as well. She was started on fosfamide and etoposide. She also had a fracture in her right femur as well again, and she developed shortness of breath in January, had a new CAT scan that was read as having a new segmental pulmonary embolism, and then a subsequent staging scan or surveillance scan that showed a femur mass was growing, so she was having some progression. She had an IVC filter placed because she had complications with bleeding, so she couldn't get beyond anticoagulation. She underwent surgery in January of this year and had a total right femur replacement. And then a new scan in March showed that she continued to have this mixed response in her lungs, but no recurrence in her femur. And then in March of this year until present, she's been on gemcitabine and docetaxel, and then May was enrolled in the TRACK study.
So thank you, Jacob. I don't know if anybody has any questions about the history. Basically, young person with a long history of osteosarcoma, which is a rare cancer, and with a lot of prior therapy, a lot of therapy of every type, surgery and and a lot of different types of chemotherapy. We will move on, and this is actually what usually happens. We get the liquid biopsy results first because all you have to do is draw a blood specimen. And for tissue biopsy, it takes longer because you have to find the tissue and ship the tissue and so forth. So Dr. Julia Elvin, if you want to discuss the findings here.
Thank you. So just to orient everybody, a liquid biopsy is a peripheral blood sample that takes advantage of the fact that small amounts of DNA from both your normal cells and tumor cells are shed and are present in the plasma component. So we utilize this feature in the TRACK study to look for any information about the mutations that are present in the patient's tumor that we can make treatment decisions on. So this assay assesses over 324 different cancer-causing genes, looking for all types of alterations in those, including point mutations, insertion deletions. We can pick up fusions and copy number alterations in some of the genes. We also assess complex biomarkers such as microsatellite instability status, MSI, and can make an assessment of potentially the antigenicity of the tumor by the tumor mutation burden. So as Dr. Kurzrock said, the patient was enrolled in May. This blood was drawn in June. And we had her results about a week later, ready to discuss at the tumor board. And so what we found was, first of all, there's another biomarker that we've come to report on and we think is very useful, which is called tumor fraction. So remember I said in the plasma, it's a mixture of DNA from normal cells and tumor cells. So if it is, if more than 10% of the DNA fragments are coming from the tumor, then we would know that the tumor fraction was elevated in this particular case, and that would give us confidence that there had been an abundance of tumor DNA to assess. Here, we didn't see it elevated. We also did not detect microsatellite instability or an elevated tumor mutation burden. What we did detect was a TP53 splice site mutation. Now, in a liquid biopsy, as we heard from Dr. Schwartz-Levine earlier about interpretation of P53 mutations, in the blood biopsy, we're thinking, is this coming from the tumor? Is this coming from CHIP, which is also one of the components that sheds DNA into the liquid biopsy, or is it potentially coming from the germline? With osteosarcoma being one of the kinds of tumors that are associated with P53 germline mutations. So in this case, the variant allele frequency of this was approximately 0.5%. So this is a very low allele fraction, and so not suggestive of it coming from the germline, and more consistent with either clonal hematopoiesis or the tumor. And luckily in this trial, we get the tumor tissue for cases like this to help us sort out that final question about tumor-derived versus clonal hematopoiesis-derived, particularly in an osteosarcoma where P53 mutations are the most common alteration that we see in this tumor type.
So thank you. So that is one of the issues with liquid biopsies is that there is contamination by clonal hematopoiesis of indeterminate potential that comes from the blood, not from the tumor. And as Dr. Elvin noted, the thing against this being CHIP would be is young. That's usually something that occurs in older people, but you can see CHIP in younger people too. but the tissue really helps tell the story there. Usually, as soon as we get results, we do a molecular tumor board because we want to get something back to the patient. And we give some initial suggestions, and then those may be revised when we get the tissue results. They're often revised. So the only thing that we had here was a P53. And P53 is a tumor suppressor gene that is not considered targetable. But one thing we know about P53 is that it upregulates the VEGFR, vascular endothelial growth factor axis. And we've published several papers showing that patients that have P53 mutations respond to inhibitors of VEGF or VEGFR. And other groups have published on this as well, including Kohler, who published specifically in P53 altered sarcomas, and including a group that was cooperative group, Sloan Kettering, about P53 and gynecologic cancers, all showing that P53 makes tumors more susceptible to VEGF-VEGFR inhibitors. So when we had the initial discussion about this patient, the recommendation was to give pazopanib. Pazopanib is a small molecule inhibitor that is approved for sarcomas, and it does a lot of different things, but one of the things it does, it's a very potent VEGF-VEGFR inhibitor. That was our first recommendation that went out with our first MTB. And again, if anybody has any questions, happy to entertain them. Then we found, we got the tissue back. And now the tissue turned out, as it often does, not always, but often, to be very informative. And it showed again that the patient was microsatellite stable, tumor mutational burden low. This is important for immunotherapy. Microsatellite status unstable or high tumor mutational burden predisposes to immunotherapy responses. But now the patient had a whole group of alterations. So the first thing that I think is very important to notice, which I tried to allude to in my previous talk, this patient has 7 alterations. So how lucky are we sometimes when we give a single drug that we actually get responses? But if people want to ask, why doesn't everybody respond? Well, the answer is sitting in front of you. It's because there's more than one driver, and probably we need to counteract as many drivers as possible. So the other thing that this tissue told us is that the P53 was not CHIP. It was there in the tissue. The same P53 mutation was there in the tissue. And we have a scientist, Pradeep D, that works with us, and he's not here today, but he always prepares these beautiful diagrams of what is going on in the patient's tumor, and he tries to put it together with what drugs can be used. So it turns out that KIT, PDGFR alpha, and KDR were amplified. And there's a good reason that they're co-amplified. They're all on the same amplicon. They're all on the same region of chromosome 4, Q12, that's the long arm of chromosome 4. And so there are drugs that can hit all 3 targets. Pazopanib is one of them, but doesn't hit these 3 targets very strongly. There's another drug called axitinib which is approved for different cancers like lung cancer, which actually hits all 3 targets very strongly with a very low IC50. And axitinib is also a VEGF-VEGFR inhibitor. So even though pazopanib is still a good suggestion, axitinib is probably a better suggestion because it's a more potent drug against these particular targets. Patient has a TSC1 alteration, and TSC1 activates the PI3 kinase AKT mTOR pathway, and drugs that are approved, there's several of these, but the 2 that are mentioned are everolimus and temsirolimus that downregulate the mTOR pathway. Now remember, none of these drugs are actually approved for osteosarcoma. It's a rare disease, and what is approved is chemotherapy, and then pazopanib is approved for sarcomas. CDKN2AB loss, this patient does have CDKN2AB loss, and there are several FDA-approved drugs. There's actually 3 that target this abnormality. One is palbociclib, one is abemaciclib, and ribociclib. So there's 3. He mentions abemaciclib here, but it could be any one of the 3 drugs. Now we're beginning to think about how do we co-target all of these alterations at the same time. Based on the tissue results, the preferred match therapy recommendation was for axitinib, which was preferred, or pazopanib. Pazopanib, the advantage is it's approved for the indication. The disadvantage is it's not as strong an inhibitor as I mentioned. And in combination with a CDK4/6 inhibitor, such as abemaciclib, and we'll show you in a little while a case report that's very similar of a patient that we treated in this way at UCSD. And we also, in order to maintain safety, we recommend starting both drugs at 50% of the dose, and then titrating up to patient tolerance. And this is what we did in the iPredict study at UCSD, which was the precursor to the TRACK study, and again, found to be a very safe way of dosing drugs. And then if a third drug is to be added, we would add an mTOR inhibitor such as temsirolimus or everolimus, again, reducing the dose significantly, at least at the beginning. So that would be the recommendations that came out of the MTB as far as a customized combination. So Dr. Nikanjam, did you want to talk a little bit about dosing?
Sure. For iPredict and for our TRACK study, as Dr. Kurzrock mentioned, it's really important to start at lower doses. But there's a fine line between a super low dose and one that's efficacious. So we needed information to guide us on what safe starting doses would be. So Dr. Kurzrock and I did several studies over the past few years, which are listed in the references here, which looked at clinical trials and dosing combinations from phase 1, 2, and 3 data. And these studies encompassed information from close to 100,000 patients. And the observations we saw from these clinical trials were that some sorts of drugs, mTOR, PARP, and HDAC inhibitors, tend to be more toxic when given in combination. Antibody drugs tend to be less toxic than small molecule inhibitors or the classical cytotoxic chemotherapy. And if you have overlapping targets, for example, 2 VEGF inhibitors, these small molecules can be a little more toxic when given together. So based on what we saw and these rules, in general, for patients that are enrolled on TRACK, when we're giving novel combinations, we start most of the small molecules at a 50% dose. Many of the antibodies we'll consider starting at full dose. And certain other drugs, especially those in the mTOR, PARP, and HDAC class, we'll often start those even lower at a 25% dose. And as Dr. Kershak said, it's really important to start low and then escalate the dose within the patient so we can get to a dose that's still safe but also efficacious. So these rules are important for the TRACK and the TRACK trial and also for iPredict, but going to the next slide, if we think about patients that aren't on clinical trials, standard of care drugs, most patients that are getting standard of care treatment don't represent the clinical trials population. They're older, they're sicker, they're on more medications. So some would argue it's important to consider dose reductions initially for patients even on standard of care combinations or single agent chemotherapy or other drugs. So Dr. Kershak and I had put together a commentary addressing this, and you can see on the left there are many factors which can affect dosing and need to be considered in the starting dose. And if patients have these, we would want to start them at a lower dose. And it's important to take the tools that we have on the right to come up with personalized, optimized dosing for both clinical trials patients, patients on the TRACK trial, and patients getting standard of care treatments.
So thank you. So, and I want to really emphasize that last point by Dr. Nakanjam. Although we started doing lower doses and escalating, we escalate by seeing the patient weekly, doing blood work and seeing how they're doing, or we may de-escalate. We discovered that this was not only good for de novo combinations, it's actually good for everybody because a lot of patients don't tolerate the approved doses. And this is, it just makes sense. You have a 20-year-old in clinic that unfortunately has cancer, and you have a 70 or 80-year-old in clinic, they're just not going to tolerate the same dose. Next, we also always talk about, and in fact, we prioritize trying to get the patient on secondary clinical trials. And Dr. Vivek Sabaya is a world expert on clinical trials, and if you want to talk a little bit to us to what is available for this patient.
Thank you so much for the opportunity. As you can see here, this is one of the highest quality tumor boards that gives drug doses, combination regimens, and then clinical trial-based options now, right? So again, what are the clinical trial-based options based on the molecular profiling? As you saw that, there was a TSC alteration there. Based on that, phase 2 basket study of nab-sirolimus in patients with malignant solid tumors with pathogenic alterations in the TSC1 altered genes, the precision 1 study. So that could be a potential option. In fact, this drug, nab-sirolimus, has an FDA indication for an extremely rare cancer. We call it PEComa. And PEComa is probably 50 to 100 cases a year, and it's like a zebra con, right? So again, the drug has an indication. It's albumin-bound form of sirolimus, has a deep activity in that. So now it's open for all tumors that harbor TSC1 alterations. So that could be an option for this patient. Another option is, again, based on the c-KIT or PDGFR-A, the avapritinib option. Avapritinib basket study will also be an option for locally advanced metastatic solid tumors. And I see some folks smiling. I see folks from the precision 1 study and from the avapritinib group here. It was not intentional. I just happened to see both of you guys here from the companies. And interestingly, CDKN2A loss. Patient has CDKN2A loss and B loss. So again, this can open up doors for MTAP testing, MTAP IHC testing. And if there is MTAP loss, this opens up to at least 8 clinical trials with PRMT5 inhibitors or MAT2A inhibitor clinical trials. Again, do you want to talk to us about MTAP loss and CDKN2A?
Well, so there's a couple of different ways to detect it. So we can detect the gene loss, but that's not the only way that you can lose them. So the coincident or downstream effect of losing the protein is also a possibility. So I think that's what you're referring to, but we don't do it in this trial, but I think that's one of the great things about the molecular tumor board is that we also talk about additional diagnostic testing that might be sought by the patient at their local institution if it's warranted.
Oh, absolutely. I think we just don't talk about the next line of therapy, but we want to be ready for the next lines of therapy for these patients. Again, pazopanib, right? Again, why do we need some are wondering why pazopanib, why do you need a molecular tumor board for pazopanib for sarcoma, osteosarcoma? In fact, the FDA label for pazopanib is soft tissue sarcoma. It's off-label use for osteosarcoma. Of course, pediatricians and pediatric oncologists and medical oncologists use that as a last line. In this case, we would not use this as a last line. Pazopanib is now indicated based on the molecular profile of this patient. In fact, it's interesting to see VEGF and mTOR pathway activated. There is a phase 2 study with sorafenib and everolimus. Did not meet the endpoint. It had a 45% patient adherence, clinical benefit rate at 6 months. So that did not meet the endpoint, but that's still an active regimen that has a phase 2 dose. So again, these are the clinical trial-based options for our patient here. Thank you, Dr. Kazra.
So I think, thank you, Vivek. So I think that the important thing here is that we try to, we have expertise in clinical trials and customized combinations, and we try to offer to the patient many possibilities, including clinical trials and including customized combinations. So this is a young patient. If Catherine Skifos could speak to germline testing.
Absolutely. So as Dr. Elvin mentioned before, the TP53 mutation that was identified on the somatic testing was at a low variant allele fraction, which makes us less suspicious that it would be of germline origin. Nevertheless, this patient was a teenager when she was diagnosed with a sarcoma, and so because of that, she should consider genetic counseling and testing. In patients under the age of 30 with osteosarcoma, about 5% or so will be found to have a germline mutation in TP53, but as the patient gets younger, that number increases. And even though the TP53 mutation was not particularly suspicious on this test, I did include here that NCCN guidelines give a bit of guidance for when to consider testing. So to echo what Ali was saying in her previous presentation as well, TP53 is the most commonly mutated gene somatically, but in patients where there is a TP53 variant identified on tumor-only sequencing, germline testing should be considered if there's relevant family history or if the patient is diagnosed under the age of 30 with any cancer. So that does provide helpful guidance in taking that next step as to whether or not to recommend germline testing. And then other genes may also be considered for this patient, germline testing based on family history. There's some preliminary evidence of genes like CDKN2A and POT1 being related to osteosarcoma risk as well.
Thank you, Catherine. Again, I want to point out the multifaceted expertise, multidisciplinary expertise that we've tried to arrange for this molecular tumor board. And really, in the post-COVID era, it was made possible because we can bring together the best experts at the best places. We can bring them together weekly for a Zoom meeting, something that we really could have done before COVID, but we didn't, and now we do this regularly. So this is the update. This patient was, I think, presented around July, August of 2023, and she was on gemcitabine and Taxotere and doing well, and she actually continues to do well with this therapy. And so one of the questions you might ask is, so why did she go on the protocol? Because she's doing well with her current therapy. And what I want to say is, from a lot of experience with these types of protocols, she went on the protocol at the exact right time. So once the patient has progressive disease, especially if it's aggressive, that's late. It's not too late, but sometimes it's too late because patients don't have a lot of time, especially if they've relapsed multiple times. Tumors tend to be aggressive, and there may be a very short window in which the physician really needs to treat the patient before they're going to deteriorate or even die. So this is exactly when we want patients to go on. We want them to go on while they're still doing well on their prior therapy. Now, if she's cured, great, but the likelihood of her being cured is very small at this point because she's had multiple relapses. So at some point, we think that she will have progressive disease, and now we have a treatment plan for her. And if it turns out that she's responding for another year or two, we can always do another liquid biopsy. We can always update the molecular tumor board. There may be new clinical trials that are available and so forth. And then I want to talk about an example of a patient that we published from University of California while I was there with the iPredict study. Very similar story. This publication is on a 31-year-old woman with heavily pretreated metastatic osteosarcoma, just like this patient. She had alterations in the cyclin pathway. They were a little bit different than the current patient's alterations, but they essentially did the same thing. She had a CDK4 and CCND2 amplification, which upregulates the CDK4/6 pathway. And so we got a CDK4/6 inhibitor for her called palbociclib, and that was one of our suggestions for this patient, palbociclib or abemaciclib. The patient in question also had abnormalities in the FGFR pathway, so a little bit different than the current patient, but again, very much in keeping with that every patient is unique, but they often have some commonalities. So she was given, together with palbociclib, lenvatinib, another FDA-approved drug. Both drugs were, even though she's only 31 years old, both drugs were given at a considerably reduced dose, probably about 40% of the normal dose level. And although we tried to increase the dose, despite the fact that the patient was only 31, she could not tolerate an increased dose. But in spite of that, more drug for these targeted drugs is not necessarily better. For chemotherapy, we always thought more drug is better. But for targeted drugs, once you hit the target, everything else may be toxicity. So her PET scan showed 68% reduction in metabolic activity. So she had a very strong partial response, and she continued to do well 51 months from the start of therapy. So very durable, ongoing response with a customized combination that she tolerated very well. So I think a good example for our current patient with osteosarcoma as well, who has similar but not identical alterations. So I think we will stop there, and then we're happy to address any questions that anybody has.
Hello. So I guess I have like two questions that are kind of like back to back. So for the slide that talked about like there are like 3 to 4 like mutations all in chromosome 4, is there any control or like investigation into if those are all independent events, or if it's just, oh, that part of chromosome, because like one of those is actually doing something? So is there like, I guess, is there any investigation into, are all those mutations on chromosome 4 independently doing something? or is it just like that chunk of DNA, and like one gene just takes like other friends with it? And then, is there any other metric than prevalence for determining which genes should be considered for targeting? In terms of mutations happen all the time. Not all these mutations may be actually contributing to any oncogenic process. So is there any other like factor besides prevalence used in determining which drivers to target?
I'll start with the first question, and it's a very astute observation. So there are clusters of genes that happen to be, known to be cancer-causing or cancer-related that often can be lost or amplified together. So in particular in sarcomas, and in this case, one of the things we did observe in her tumor testing was quite a bit of aneuploidy, which is a typical thing that we see in sarcomas. So I guess like it's a little bit of hand waving to say that yes, sarcomas are a category of tumors that often have these arm level or chunks that have either loss or amplification. And I think it's an area of exploration to figure out, as we're starting to target multiple of these alterations, we'll learn a lot more about which ones, if not all of them, are actually working in conjunction with one another. Maybe you can take the second question about the prevalence of, or the variant allele frequencies, I think, maybe around which ones we try to target first.
Yeah, so it's a really good question. We accrued on the UCSD, we're about 170 patients into the 400 on track. So we don't have readouts yet, but we accrued 500 patients on the iPredict. And we had this really great idea. We figured out the degree to which patients were matched, and we published that. And then we had this really great idea that we would layer the variant allele frequency over. And that it would be important because we thought it's going to be important. And then we did the study, and you don't see it published because we found that it had no impact. So why didn't we publish the negative results? So because when we looked at it, the outliers that had very low or very high variant allele fraction and yet were targeted, were only a small number of patients. And because they were a small subset, our statisticians said that we didn't have enough power to prove the negative. And the statistician was worried about us publishing something that was negative that really wasn't statistically powered to answer the question. So I don't think anybody knows the answer to the question. My gut feeling is that VAF is important, but so far we haven't been able to show it, and we don't have the right data to show it.
I think one other kind of emerging concept that is going to, I think, complicate all of this is, there's ideas that sometimes tumors in the patient are actually already heterogeneous and are comprised of, maybe multiple subclones versus other patients have a more of a homogeneous mass. And I think this is going to be a very interesting area to explore, whether sometimes what we're observing is a subclone emerging, or sometimes what we're observing is actually like a multiclonal process already. So never a dull moment in tumor testing and treatment.
No, absolutely. Again, VAF also changes, right? So the tumor sample could be from diagnosis, and then patient receive chemotherapy and is progressing. The VAF goes up, new genes pop up, right? So again, it keeps changing. So it's dynamic. So again, at every point, it'll be great if we have tissue and a liquid biopsy to address, the current state of the tumor.
Thank you very much for sharing, walking us through the thinking process, how to treat this patient. So I found that this is very fascinating, especially hearing on one side, you see so many different mutations. You could do the combination with this particular trial versus there are other trials out there more focusing on one particular mutation, one target treatment. So in the end, of course, you guys decide to do the combination, but it's also showing a trend in the future, one drug, one target therapy is going to be out of fashion, and people are more thinking about do all this combination. So I'm not a doctor, so I would love to hear what you guys are thinking about, what this is going to lead to the future. Thank you.
No, absolutely. I think the current paradigm is just one drug, one gene, we move on, right? So, but we even with that testing, what I showed earlier, like red fusions, we don't have 100% complete responses. So ideally, right, we have even with the best of the best case scenario in the tumor agnostic setting, we have a 55% response rate. What happened to the rest of the patients? Probably it's driven by the co-occurring alterations, co-occurring PI3K alterations with the RET alteration. Ideally, we should do customized combination therapies for each and every one of those patients, right, to get to reach to 100% complete response rate. So again, science is evolving, and again, this is a pilot study that can show to the world that customized combinations can be done in the real world setting. Of course, it was demonstrated in UCSD. So, we learn from every clinical study.
Happen to be meet, if this patient's indication happen to meet one of the clinical trial, would you kind of prefer move that patient to the clinical trial, like the specific trial versus this kind of basket trial? No, not basket, but this innovative trial.
Again, it depends how where the patient is, how the patient is, how the clinical performance status of the patient is, how motivated the patient is. Again, my preference is always on a clinical trial. So TRACK is a clinical trial, by the way, right? So again, technically, patient is enrolled on a clinical trial, and if we can enroll on a prospective study that has good activity, we would recommend a prospective clinical trial. Happy to have Dr. Kershaw answer
so
that
we always prioritize secondary clinical trials. Some of the drugs that are being developed are very powerful and more powerful than the current drugs. But we do realize on a practical basis, the patient may not have the clinical trial locally and they may not be eligible. So we give them more than one option. I also wanted to address the fact that patients have a lot of co-targets with something that we didn't talk about today, but I think is very important. Before I was a solid tumor doctor, I was a hematologist, and I was very involved in the chronic myelogenous leukemia story. So chronic myelogenous leukemia is a disease transformed. When I was a young faculty, it was a death sentence. Everybody died in about 3 to 4 years. Today, patients have a near normal life expectancy. And it's based on that there is a fusion called BCR-ABL that occurs in chronic myelogenous leukemia. And we have drugs like imatinib that target it. And one of the questions that comes up is, so why doesn't that work that well? And the response rates are close to 100%. And the patients have a near normal life expectancy. So why don't we get that in solid tumors? And a lot of people claim it's because solid tumors are fundamentally different. But having worked in both fields, I don't believe that. Because if you take chronic myelogenous leukemia and you treat end-stage disease, and end-stage disease is probably equivalent to metastatic, heavily pretreated cancer, the response to imatinib is negligible. And the improvement in survival is only about a year, which is what we often get. The key to getting a normal life expectancy in chronic myelogenous leukemia was not only knowing the aberration and having a drug, but treating at the time of diagnosis. So we have not historically done that in the solid tumor space, although we now at MCW have a protocol that's open to patients that are newly diagnosed, but I think that has to be part of the answer. Metastatic disease needs customized combinations. It's complicated. One drug, we are lucky that we get responses, but we're going to need to use more drugs. And we need to move these therapies up front when the disease is not so complicated and equivalent to newly diagnosed chronic myelogenous leukemia.
Great discussion and great tumor board case. I have essentially a follow-up question to what was asked before about the combination therapies. The study is ongoing, so you may not have the answer on this yet, but what is the acceptance rate of doing combination therapies in the community of the physicians that are, taking care of these patients that are enrolling on track?
I can speak to that because I did my residency at Kaiser and I do somewhat community practice as part of UCSD. I think it really depends on where the patient is in treatment. Unfortunately, as Dr. Kershak said, we really do need these therapies up front, the combinations to help patients. Most of the community doctors, and it depends on the community doctor, if it's front line, they're a little nervous to do something not standard of care unless there's no good standard of care. But in general, as you get to second or third line and the patient's rapidly progressing, then they're open to trying anything to help their patient. So I think it's going to take some time and education and data from trials like this just to show that it's safe and it's okay to do. But a lot of oncologists at Kaiser, other community practices, many of them are very nervous to do custom combinations early on, which is what we need, and hopefully with time that will change.
And Vivek, did you want to address that about community versus academia, since you've had a foot in both doors?
Yeah, no, absolutely. I think it's I know right now I see it's the other way around because academic oncologists, it's so tough to get a combination drug past the formulary committees in academic institutions. So for instance, a lung cancer patient walks into the door, patient has osimertinib, great response, 6 months later, patient progresses. And there is a MET amplification. In an academic institution, forget it, you can't get osimertinib and capmatinib or tepatinib added on. Community doctors routinely do that. And again, some of them don't even realize that this is not even used before because they're like, oh, we are treating the EGFR, we are treating the MET, and we keep going, right? So it's, they do that and they are so busy they don't even realize that that it's not been published yet. So in fact, we have acquired an AI company that is ingesting all the clinical data, that is data dumping from every company, from Foundation. We get all the reads, raw data, and we are going through all the molecular profiles, and we are getting the raw reads from all the drugs that have been prescribed across the board and the drug distribution, see how we can match that, and see how much of customized combination therapies are going on across the 1,400 doctors. So maybe for the next meeting, we'll be happy to share that with you. It is taking time, right? So we are doing contracts with each and every state to get all the data. So it will take time, so we'll get there.
Yeah, so my experience is kind of similar. In academics, we've had a protocol, like I predict, UCSD and now at MCW. But looking at what I've seen in community practices, there's some practices that restricted with certain types of health systems, but other practices, I would agree with Dr. Sabaya completely. The community physicians have been doing this forever, and they just do it as part of their practice. And I think it's wonderful that Sarah Cannon, US Oncology, will be curating the data, because I think that there's going to be a lot of discoveries there.
And I think just to add on to this, so actually in a similar vein, so Foundation Medicine has had a project with Flatiron Health where we have we've tested over 1 million patients, so we have profiles, and Flatiron has clinical outcomes from a lot of community practice sites, and we have a combined overlap of over 100,000 patients that have profiles and therapy. And while certainly the number of patients that get, that we can look at and see how they respond to therapy, it definitely goes up once they're an approved indication. But it's actually really interesting to ask questions that sort of are anticipating what might be next, because there are people who are trying things out. So for example, in a tumor board, it came up that a patient who had microsatellite unstable endometrial cancer, part of a Lynch family, had had chemo with her colon cancer. She was not going back on chemo, so did not want to do the first-line chemo for her microsatellite unstable endometrial cancer. And the question came up, can we just give her like pembrolizumab as first line for this patient? Well, it wasn't approved as first line, and she was being treated at an academic institution. But we actually looked into this database, and we found just naturally a number of sort of N of 1 experiments in there, and we're able to see that it was look at the overall survival data for these patients with the biomarker and the targeted treatment, and they had better overall survival compared to people with the same biomarker that got chemo. So I think there's like, the takeaway is that I think we're not capturing all of the learning that we can unless patients are in a clinical trial, or unless we have these kind of databases that can show us the variability in practice and response to help us power the next level of trials.
So I can
So I think we're basically out of time, and I see there's more questions, but I don't want to take away from the next presenters. So if you have more questions, do you want to? Okay.
Yeah, this is a two-prong, and hopefully it won't be that long. But I'm curious about the concept of deciding on combinations, right? And do you always decide to give them simultaneously? Do you ever sort of think about the order of giving them? And then my sort of related question is, you're gathering information along the course of this clinical trial. How much is the early patients influencing the decisions you make about the later patients, and how does that affect the interpretation of the results of the clinical trial as a whole?
So this clinical trial hasn't been going on long enough to answer your second question, but we did look at it. Actually, we looked at it first at MD Anderson, and which was much earlier, and then UCSD, and there is no question that we get better. Not only do we get better, but the FDA-approved drugs get better. These trials, the UCSD trial was activated in 2015, and TRACK has already been going on for, I don't remember, about 3 years. So if we look at earlier cohorts versus later cohorts, we have better drugs, we get smarter. So there is a learning process that occurs. That probably occurs with all drugs, even single drugs on clinical trials. You learn how to dose it, you change the dosing, and so forth. And then you have a really, really important question that I don't think we've answered. We have some behind-the-scenes data, but that's like, the question is, if we gave it in combination, could we do as well if we just gave it serially? And we don't have that question. We haven't published the answer to that question, but we've looked at the UCSD data, and often if the physician was hesitant to give the combination, they started with one drug, and then when the patient failed, they gave it serially. And the overall survival for those patients, it's not a clean study, it's not a randomized study, but the survival was less when we looked at it. So I don't want to say that we know that 100%, but behind the scenes, we did look at that. So thank you for the questions. Okay, thank you.
May I just make one quick comment? I just want the audience to know, because thinking outside the box, this patient, if it was just intraparenchymal metastasis without pleural or the mediastinal lymph node involvement, would be a perfect candidate for double lung transplant going forward. So that's just thinking outside the box. We took care of the primary tumor, so it's gone, and then patient stood test of time, it's always just progressing only inside the lungs, then that we have that option as a, another clinical trial. So.
Thank you.
Thank you.
Thank you. Okay.
Thank you.
Thank you, everybody,
Thank you.
for participating.